Right, I'm going to talk about Section 136 of the Mental Health Act 1983, potentially one of the most difficult bits of legislation I've ever come across, because only the police can start it, only the NHS can end it. Nobody's written down where the transfer of responsibility moves from the one organisation to the other. The law and the various statutory and other guidelines say that lots of things have to happen, but it doesn't necessarily specify who should do them. Consequently, lots of well-intended professionals on either side of the police-NHS fence will say that the other organisations should do more than they're doing, or they should do it differently, and therein lies the confusion. We've got these two massive public organisations, health and policing, and they have to come together in an emergency to ensure the welfare of somebody who's even more important than any of the professionals involved, and that is the person or patient who's being detained under the provisions. So this input is a short few minutes on how to get 136 of the Mental Health Act correct in a way that takes account of the law, the guidelines, the statutory guidelines and the codes of practice, the Royal College standards and so on, and it also takes account, in my opinion, of the fallout from different incidents we've had in this country where 136 of the Mental Health Act has gone awry for a range of different reasons. The structure I'm about to explain, I would submit, would protect the professionals involved from any suggestion that they've either been negligent or casual with regard to the welfare of somebody at the centre of their decision. So 136 of the Mental Health Act. It's a police decision to initiate this power. It can only be initiated in a place to which the public have access. That means obviously it can't be used in somebody's private dwelling, nor can it be used outside somebody's private dwelling where they've been, let's say, invited to move from a private place to a public place, potentially with a view to the power being exercised. That would still be unlawful because the person would not be able to be said to have been found in a place to which the public have access. So 136 goes like this. When a police officer has made a detention under the Act, they should call an ambulance immediately. And when the ambulance gets there, or even if it doesn't, the officer or the paramedics or both should do an assessment of what needs to happen. That's what I call the 3 A's. Make an arrest, call an ambulance, do an assessment. And that will trigger a consideration of where the person is removed to as a first choice place of safety. Anybody who's detained with something called a red flag should go to the nearest accident and emergency department. It means they either need treatment for injuries, treatment for medical problems, or it means the nature of their mental health presentation is something that needs to be regarded as a medical emergency. And this is absolutely key. This is the learning from some of the coroner's inquests, IPCC inquiries, and other untoward tragedies that we've had in this country. Some mental health presentations of themselves can be indicative of a medical emergency, or the consequences of restraint arising from detaining someone can amount to a medical emergency. So red flags go to A&E. If somebody's detained without a red flag, they need to be taken to the nearest psychiatric place of safety that's been set up for the purpose of receiving people who are detained under 136. When you get there, that's where you have the discussions about whether alcohol, aggression, violence, drugs, intoxication, age limits and so on is going to be something that represents an obstacle in the minds of the NHS in that area. It's not for a police officer to stand in a public place somewhere miles away from a healthcare professional trying to make a decision whether some alcohol is too much alcohol or whether that would bar an assessment or not bar an assessment. It's absolutely vital that the NHS are given the opportunity to understand for themselves whether or not they feel that it's appropriate for their environment to be used as a place of safety for somebody who's been detained. And whilst the NHS do have a legal option, should they feel it's necessary to say, no, you can't use this location, it is in my submission legal for the officers to remove the person to a healthcare professional and say, we think it's appropriate for you to be here, or for you to take the decision about why the person's not here after having had the benefit of seeing the patient for yourself, so that nobody's guessing as to what the nature and presentation of the patient is. And therefore, if all else fails, and if you can't improvise around the problem, we should remove somebody to a police station as a last resort. I say improvise around the problem because there's nothing that prevents the police thinking outside the box. In fact, actually, paragraph 10.22 to the Codes of Practice of the Mental Health Act says they should think outside the box. It explicitly states that the police station should not be used as a second choice place of safety, purely on the basis of the fact that the first choice place of safety is unavailable. The Code of Practice says that you should consider the alternative before using the police station as a last resort. So, for example, this is a real example. In a police force in the south of England, the police had detained a young woman who had self-harmed, quite an immature-looking 13-year-old girl, and having awareness of the fact that the local place of safety would not accept anyone under the age of 18 in any circumstances, the police officer was faced with the option of cell block or cell block. Feeling that this wasn't going to be quite right for the girl, and knowing perfectly well that the cell block was full of people in quite a agitated state of distress, having been arrested for burglary and drunken disorderly offences and so on, the officer took the girl to her own home address with a view to assessing whether that was a clean and safe environment in which the girl could be detained for a doctor and an AMP to come to the house and do an assessment. Obviously the officer was thinking along the lines of, if the house is unclean, unsafe, if the parents are uncooperative, it might not be appropriate to use that place, and then it may be that we have to use the police station. But as it happens, when the person was removed home, mum was there, it's a clean, safe environment, people very concerned and distressed that the police had become involved but understood why they had, and when the officer offered the opportunity for the mother to put on the kettle and tolerate a cop in her front room for several hours pending the assessment, or to have her daughter removed to a police station as a place of safety, mum went straight into the kitchen and put the kettle on. The doctor and the AMP attended the home address, the assessment was done there. On that occasion the girl wasn't detained, but the appropriate care plan, the appropriate aftercare was put in place after the officer left. Girl safeguarded, use of the police station avoided, absolutely legal and absolutely not written down in the local protocol as a way to deal with section 136, but it would be a lawful way of dealing with 136. The reason the police are objecting to the use of places of safety is because one half approximately of the deaths in custody in police stations reported on annually by the IPCC are connected to people who have drug, alcohol and mental health presentations, and certainly some of those include people who were in a state of some agitation or resistance at the point where they were arrested. The figures are so pronounced that when you examine the cases concerned, you start to find examples of where allegations can be made that the police had ignored the impact of restraint on someone, rendering it a medical emergency, or the police had not taken sufficient steps to ensure that alcohol wasn't masking any other underlying problems. Of course, the problem with police officers or even paramedics making snap-second judgments about whether somebody's got a mental health condition is that presentations consistent with what we think might be a mental health problem could in fact be any number of other medical problems, which include serious medical problems. These can include things like diabetes and blood sugar problems, it can include epilepsy, strokes, in some cases it can include heart attacks, Addison's disease, the list goes on, to try and suggest that an officer should be making a judgment about somebody's medical condition from a roadside or sorting it out in police custody when everything's calmed down is too casual an approach to take to keep somebody safe. So 136, to recap, is call an ambulance, make an arrest, call an ambulance, do an assessment, the 3 A's. When you've done arrest, ambulance and assess, you then go red flags to A&E, no red flags to the health-based place of safety in your area, and if all else fails, and if you can't improvise around the problem in a sensible and responsible way, the police station is a place of safety of last resort, and nothing prevents it being used if you've gone through those steps. There you go, that represents a test input. I'm going to put this on YouTube. It's a few minutes long. You can tell me what you think, and if something like this on other topics like 135, AWOL patients, community treatment orders, prosecution of offenders, inpatient violence and so on, if any of that would be useful in this format, I'll certainly take the time to do a few more. But I'm going to put this up and take the feedback and see what people think, see whether they think it's useful. And if it is useful, somebody will have to teach me how to do bits of graphics that I can stick on the screen in front of my face, so that we can have a few charts and diagrams and reminders or key bullet points and so on and so on. There you go, feedback welcome, let me know what you think.